delivered by Dr. Gaurav Jayani, Senior Health Economist at the PGIMER Chandigarh. Dr. Gaurav Jayani is currently working as Senior Health Economist at HTA Resource Hub, Postgraduate Institute of Medical Education and Research, Chandigarh, India. He holds a PhD in health. Earlier, he graduated in dental surgery and his post-graduation degree in public health with health economics as the primary subject of interest. His research interests include health technology assessment, health financing, health benefit package design, patient-reported outcomes, value-based care, healthcare priority setting, and universal health coverage. In addition to contributing to capacity building for HTA in India, he has been actively involved in the conduct of economic evaluations for the HTA for last 10 years. He has authored numerous research papers and book chapters on cost effectiveness of healthcare interventions, patient reported outcomes, priority setting, and universal health coverage. His work on the development of EQ5D value set for India is serving as a useful resource for conducting cost effectiveness studies in India. Additionally, the findings from his doctoral research have been utilized by the Eurocall Foundation to enhance the design of valuation studies across different countries. In this session, he'll be discussing how the CEA and CUA play a critical role in shaping the HTA frameworks, guiding evidence-based decision making, and ensuring the best use of limited healthcare resources. Before we begin, I'd like to inform everyone that we'll have a quick Q&A session right after this talk, so please keep your questions ready. Please join me in welcoming Dr. Gaurav Jayani. Over to you, sir.
Thank you so much, Fatima, for the kind introduction. And in the beginning, I would like to thank Dr. Richa and her team, whole of the organizers team, which is here with us, for giving me an opportunity to discuss my thoughts with you on this topic. And I would like to congratulate them also for organizing such a wonderful event. So as Fatima has just been discussing that yesterday we primarily talk about the underpinnings of HEOR, and today we will move into the practical applications, which is economic evaluations and health technology assessment. So in this particular session, in next 30-35 minutes, we will primarily be discussing two aspects. One, what are the underlying philosophical approaches of economic evaluation? What are the different types of it? And when we apply these things in practical, so that is called health technology assessment. So how it is currently being used in the current healthcare landscape of India. So I will be sharing my slides. I hope my slides are visible in full view.
Yes, Dr. Gaurav, we can see them.
Great. So as I have mentioned that primarily we will be discussing two things. The first part pertains to economic evaluation per se, and second part pertains to its practical application. So before we, let me switch on the laser pointer also. I hope the laser pointer is there because the controls are a bit different from the usual Zoom which I use.
Yes, we can see.
Yes, now it's working. Thank you. So the basic need of economic evaluation is that in our health system, we are facing a situation in which we are quite resource crunched. And because of this, there is a huge discrepancy among three things. That is, what is the requirement of resources? Second, how much people who are working in the health system, they propose that this grant should be allocated to them. And then what is the amount that has been sanctioned to them? So there is a big difference. So when we move from top to bottom, there is humongous reduction. And this is because of the reason that our health needs are infinite, but the resources that we have in our hand that are quite limited. And in our health system, there have been various interventions which are worthwhile, which are worth implementing and efficient also. For example, if we talk about some of the widely prevalent cancers, one of them is cervical cancer. And if we want to detect cases early, there are different cervical cancer screening strategies that we can roll out in the population in order to improve health of the population. At the same time, there are some advanced treatment or curative interventions. For example, for thalassemia patients, there is bone marrow transplant that is available. Its impact on improvement of quality of life of thalassemia patient as well as their survival is tremendous. But the downside is the cost is very high. So we have various such curative interventions which are there in our hand. Then there are certain interventions which are very cheap per se, but there are a lot of people who are demanding those things. For example, certain medications for hypertension. So in ideal scenario, what happens that our health system has ample money. And with this money, we can roll out cervical cancer screening program also. We can offer bone marrow transplant to thalassemia patients also. And we can also offer these amlodipine atenolol tablets to people who need them, our hypertensive patients. But the reality is not this. The reality is that we have very limited amount of money. And because of this, if we say yes to one intervention, we will have to say no to other two interventions. Now, this is where the concept of opportunity cost comes in. Opportunity cost is the cost of next best alternative, which is foregone. For example, if you look at the screen, if we are saying yes to the cervical cancer screening strategies, probably that money might have I think there was some problem with audio. I hope I'm audible, isn't it?
Yes, Dr. Gaurav. We
You're
can hear
perfectly
you.
audible, Dr. Gaurav.
Yes. So if we say yes to cervical cancer screening strategies, we might have say no to bone marrow transplant or antihypertensive drugs. Now, this is the opportunity cost of saying yes to cervical cancer. And this is where this economic evaluation helps us because we have limited money and we want to achieve maximum health in the population so that we can achieve the agenda of or the targets of universal health coverage. Now, economic evaluation is one such tool that helps us to decide that with this limited money, where we can generate maximum amount of health. So what is this economic evaluation? This is essentially a comparison, and it is a comparison between two or more health interventions which are trying to answer one problem. And this comparison is always done in two aspects. One is what is the cost of rolling out these interventions? And second, what are the health benefits that we will be getting if we roll out this intervention? For example, in this screen, there are two programs which have been shown, Program A and Program B. If we roll out this Program A, there will be certain costs that we will be incurring. And at the same time, as a result of this, there will be certain health benefits in the population which will be garnered. And same goes with Treatment B or Program B also. So in economic evaluation, we compare both the treatments in terms of what is the cost that has undergone and what are the health benefits that we have garnered. And after this, we get something that we call as cost effectiveness ratio or incremental cost effectiveness ratio. And this metric tells us that which intervention will be generating more health in the population by investing same amount of money. So this is the basic concept of economic evaluation. As we were discussing now, the cervical cancer also. So now we will try to understand this with one practical example. See, for cervical cancer, there are different screening strategies which are available. For example, one is visual inspection with Lugol's iodine or acetic acid. Second is pap smear. And third is HPV DNA, which is RT-PCR based. Now, all these three interventions, they tend to do the same thing, that is screen the population for cervical cancer, but their cost is different. VIA might be cheap, pap smear might be a bit costly, and HPV DNA might be even more costlier. At the same time, the health benefits they will garner. So in screening, what happens that we detect some cases. So, and I'm sure you are aware of the terms like positive predictive value, negative predictive value, sensitivity, and specificity. So for all these three types of screening tests, these metrics are different. As a result, the number of true positive cases that each of this test detect, that is different. And as a result, the health benefit that will be there in the population, that will be different. So we are trying to answer one single problem. We have multiple interventions for that. Each of this intervention will cost us differently, and the health benefits, that is the true positive cases that we will detect in our population, that will also be different. So this economic evaluation will tell us that if we have a limited resource envelope, investing in which of this strategy will yield us maximum amount of health benefits. And this question was asked to us by Health Ministry, that which approach to use if we want to screen cervical cancer. And not only the type of test, but they were also interested in the frequency. For example, if we want to screen women for cervical cancer, should we be screening them every 3 years or every 5 years or every 10 years? Because it is not like once we have screened a woman and if she is detected negative, it is not sure that she will remain negative for the rest of her life. She might develop after 3 or 5 years. Now, the longer the gap between the two screenings, the lesser will be the cost, but at the same time, more will be the risk of missing out a case, because in this duration of 10 years, she might develop the cervical cancer and that can progress as well. So the health benefits will also be kind of limited or curated. So while designing this screening program for India, Health Ministry tried to ask that which intervention should they propose in their operational guidelines out of these three screening strategies, and at what frequency they should propose. So with the help of economic evaluation, we did this cost effectiveness analysis, and we found that if we screen women with visual inspection with acetic acid after every 5 years, so in all these permutation combinations, this will be most cost effective strategy. And once this HTA was done, it was incorporated in the operational guidelines of NP-CDCS, which is now renamed as NP-NCD. So this was just one illustration that how this tool, this economic evaluation, helps us to decide that with every rupee that is being spent in our health system, how we can generate maximum amount of health. Because I want to again emphasize why we need this, because there is I mean, the Indian health system is kind of, there is huge resource crunches there. And if resource crunch is there, we should be very cautious while spending this taxpayers' money, that every rupee that is being spent, it should actually get maximum amount of health benefit. It should generate maximum amount of health that it can generate in the population. So that was the basic of it. Now we come to the different types of economic evaluation. And if you read in the textbooks or papers, there are primarily three or four types which have been defined. The first one is called cost minimization analysis. The second one is cost effectiveness analysis. Third is cost utility analysis. And fourth is called cost benefit analysis. Now why I'm saying 3 or 4 types, because the first type which I mentioned, that is cost minimization analysis, it is sometimes clubbed into cost effectiveness itself. So broadly, there are 3 types: cost effectiveness, cost utility, and cost benefit. Now, why I'm saying that cost minimization is clubbed into cost effectiveness analysis, that we will see in subsequent slide. And before moving into that discussion, what is the basis of this division? Why we divide our economic evaluation into 3 or 4 parts? So this is decided on the basis of how health outcomes are measured in an economic evaluation. Because this we have already seen that we will ultimately be comparing 2 things. One is cost and second is health benefits. Cost is always measured in terms of currency, money, rupee, dollars, something like that. But how we measure health outcomes? Suppose I ask you that if you want to measure, or you tend to measure health of a group of people, what will be the metric you will use? So the most crude metric will be that in a specified time frame, how many people are dying. If there are 2 groups, in group A, more people are dying, you can say that health of people of group A is less as compared to group B. So there are some very crude measures like mortality. But sometimes it does not solve the purpose, because if there are 100 very young people dying and if there are 100 very old people dying, now the number is same. But if you want to comment on the status of health in 2 groups, there are stark differences. So the measurement of mortality sometimes does not solve the purpose. So we carved out some other metrics like life years saved, that how many lives, how many years of life that is saved because of this intervention. So if we are measuring our health consequences in these natural units, for example, deaths averted, life years averted, cases averted, or some clinical endpoints, or some condition specific scales. For example, if there is a scale of pain and one painkiller reduces the pain from, let us say, 70 to 40, whereas second painkiller reduces the pain from 70 to 60. So there are various clinical or condition specific outcome measures also. If in our analysis, we are measuring our outcomes in any of these types, we call it cost effectiveness analysis. Now, in cost minimization analysis, what do we do? Whenever these health consequences generated by the interventions in which we are doing the comparison, they are exactly the same. Now, the only difference will be in cost. For example, there is some antihypertensive drug. Let us take example of amlodipine atenolol tablets only. See, these tablets are manufactured by different pharmacies. They are marketed by different pharmacies. Clinically speaking, one tablet of atenolol amlodipine no matter from which brand it belongs to, it should bring out reduction in systolic and diastolic blood pressure that will be of same level, but the cost is different. So here the active pharmaceutical ingredient is same, but as it is being marketed by different brands, the cost is different. So if we are doing this type of analysis in which health outcomes are exactly same, but only difference is in cost, we call it cost minimization analysis. If you ask me frankly, it is not even I mean, a very robust kind of analysis, because we are simply commenting that this one is cheaper, the output that is generated is same, so we should go with this. So this is cost minimization analysis. That's why in various textbooks, it is not considered a separate type of analysis. They usually club it in cost effectiveness analysis. So I think the cost effectiveness analysis is clear to us now that, see, cost is always measured in terms of money. But if we are measuring consequences in terms of some natural units, then it is called cost effectiveness analysis. So this was first type of economic evaluation. Now try to imagine a scenario that there are two interventions. One is saving women from cervical cancer, and second is treating children with thalassemia. And both of these interventions are saving 100 lives. So suppose they cost us rupees 1 crore. So by spending 1 crore, 100 cervical cancer women are saved, or 100 children with thalassemia are saved. Now, which will be more cost effective? I mean, it is difficult to decide for us because a head-to-head comparison between different diseases, that is not possible here. Now, what do we need? We need a common currency that can be traded across different types of diseases. We need some single metric that will help us generate the recommendation that if 500 units of health are generated by investing this money in cervical cancer screening, and 700 units of health are generated in children with thalassemia with same amount of money, now let policymaker decide. Now the decision is very simple. He will go with 700 because by investing same amount of money, more health is generated if we go with thalassemia. Now this type of a measure is called utility-based health scale or summary measure of disease burden. And when we measure our outcomes in these terms, we call it cost utility analysis. And two most commonly used metrics in cost utility analysis for calculation of outcomes are: one, quality adjusted life years, that is QALY, and second, disability adjusted life years, that is DALY. I know you must have heard about these things various times. See, both are summary measures of disease burden. And why do we call them summary measures? Because they tend to summarize two important things in one unit. Now, which are these two things? Mortality and morbidity. For morbidity, they take into account the survival gain. And for morbidity, they take into account quality of life or disability weight. Or in other words, if we say the quality for which the additional survival is offered. So if we are measuring health outcomes in any of these utility-based quality of life scales in our analysis, we call it cost utility analysis. And I think now you can very well understand that why we need cost utility analysis, because on various instances, cost effectiveness analysis does not solve our problem. So because if we are doing our decision making, suppose at the health ministry level, so there are different diseases, and for each of the disease there are different interventions. If we have conducted economic evaluation and we are having this information in life years saved for different diseases, a head-to-head comparison is not possible because one life year of cervical cancer patient is not similar to one life year of anemia patient. So for that, we need something else, and that is we need to adjust this life year for the quality of life of these patients. When we do this, we call our analysis as cost utility analysis. So whenever resource allocation is required to be done at health ministry level, this type of analysis can solve our purpose. But there are instances when the allocation decisions are made even at a higher level. For example, at the finance ministry level, because there are different ministries which are sitting in front of finance minister asking for money. There can be education ministry, health ministry, there can be corporate and industry, and each of them will say, for example, education minister might say that if you give me 1 crore rupees, in 5 years, I will give you returns that is worth 5 crore rupees. Industry can say, if you give me 1 crore rupees, I can generate returns worth 10 years, or 10 crores in next 5 years. But if health minister says that if you give me 1 crore rupees, I will generate 500 queries, no comparison can be made. Then what do we need to do? Now we need to convert our health gains into monetary terms so that we can give information about return on investment. That if you give us 1 crore rupees, we will generate return worth 10 or 15 crore rupees. So when we convert our health gains in monetary terms and we present our results like a return on investment analysis, we call it cost benefit analysis. So I hope the distinction and need between different types of economic evaluation is clear to us now. So now very quickly we will try to see that what are different components. So as we have already discussed that there are primarily two components, one pertains to cost and second pertains to health effects. When it comes to cost, there are primarily three types of costs which we aspire to measure. One is direct cost, second is indirect cost, and third is intangible cost. So when we talk about direct cost, these are the costs which are directly borne while delivering the intervention. For example, there can be certain expenditure that is made on medicine. Then there are certain equipment that might have been involved. Then there can be human resource cost. There can be nursing personnel, doctors which are involved in delivering the care. Their salaries are going in. So that is also one type of cost. Then the patient might be traveling from far away to get this treatment. Then patient is also incurring some cost. Patient is also incurring some cost on purchasing the medicine. So all this type of cost which is directly attributed to getting the treatment or rolling out the intervention, we classify this cost as direct cost. The second type of cost is indirect cost. And this indirect cost means that there are certain productivity losses because of the disease. When we try to measure that also, we classify this cost in indirect cost. And one example is, suppose there is some daily wager. That person falls ill. Now he is not going on work. There is loss of wages. There is an economic loss to that household, to that individual, but it is not directly attributed to getting the care, but it is because of disease. So when this type of cost is measured, we classify it in indirect cost. The third type of cost, which is not usually measured, that those are some intangible costs, like if a patient falls ill, then there will be some anxiety in the patient, there will be some sense of fear in the patient that what will happen to me, but that impinges upon the patient. So that type of cost is called intangible cost, but they are very hard to measure. So how do we measure these three types of cost? The most important is direct cost only because it is directly attributed to care delivery. Now, who will bear this cost? Either health system will bear this cost or patient will bear this cost. For example, when we fall ill and we go to hospital, there is some, and suppose we go to a government hospital, there is some doctor sitting, there's a pharmacy also. There are some in-house diagnostic tests also. And usually we are not required to pay anything for that. Just one registration fee of 10 or 20 rupees that we need to pay. So do you think that the real cost of delivering all the services which we will be availing is only 10 to 20 rupees? No, there are various costs which are involved, but actually health system is bearing that cost, maybe from taxpayers' money or from wherever. But as these costs are borne by health system, we call it health system cost. But at the same time, there are certain costs that we are also bearing out of pocket to get this care. For example, the 20 rupees registration fee. For example, if we are hiring a taxi to go to our health facility, then there are some traveling costs. If we are staying in that city for 2-3 days, there will be some boarding lodging costs. So all this expenditure that is borne by patient out of its pocket in order to get the treatment done, that is considered out of pocket expenditure. So the direct cost is divided into two parts: health system cost and out of pocket expenditure. Now, when we come to indirect cost, I mean, for example, wage losses, then there are different approaches, and most commonly used is human capital approach. In some subsequent lectures, I think we will be discussing these in detail, but very briefly, what do we do here? Every person is having some ability to generate an economic worth to the country, and usually it is measured in terms of per capita GDP. Suppose for India, the value of per capita GDP is around 2 lakhs, 2.5 lakhs, which means that by working one full year, an average Indian will generate an economic worth that is equivalent to 2 lakh rupees. If 1 month of his productivity is lost because of the disease, then we calculate the loss of economic worth because of that 1 month. And how do we calculate that? In 12 months, we generate productivity worth 2 lakh rupees. In 1 month, 2 lakh divided by 12. So, and if he is ill for 1 month, he cannot work or he cannot contribute to the economy for 1 month, then we say that, see, this 2 lakh divided by 12 is the indirect cost because of this disease that has been borne. There are certain economic evaluations in which calculation of this type of cost is also done. The third type of cost that is very subjective, for example, the fear or anxiety because of disease, and we usually don't measure them in our evaluation. Suppose we are doing an evaluation, so which type of cost we should include, because there are different components. It depends on our perspective and who is our user. For example, if we are doing economic evaluation for some drug, we can restrict our analysis to the cost that is borne till this level, that is health facility level. Either it is borne by health system or by the patient in form of out-of-pocket expenditure. If there are two drugs for which we are doing our cost effectiveness analysis, we can measure all these costs and our work will be done. However, if we are doing cost effectiveness analysis of some program, if we restrict ourselves to this level, then it will be kind of a skewed analysis, because there are different community outreach programs also. There are elements of home-based care also in public health programs. There are some IEC or BCC activities, or there are some programs in which the costs are borne by the departments which are even outside health system. For example, Anganwadi or WCD department is involved. So those types of costs should also be incorporated. So whenever we do an economic evaluation, how will we decide that where should we restrict ourselves in terms of cost? That depends upon our perspective, our point of view of the analysis, for whom we are doing this analysis. So this was about cost. So far we have learned that primarily there are three types of economic evaluation: cost effectiveness, cost utility, and cost benefit analysis. However, there are some other similar types of analysis which also tend to talk about costs and consequences of health programs, but they are not economic evaluations. And we should be very careful about this differentiation when we are reading those papers or when we are using that evidence in our analysis. For example, there are two rows. The top row talks about that only a single treatment strategy is analyzed here, because there is no comparison of different alternatives. If we are only talking about a single strategy in terms of its cost or in terms of its health effects or in terms of both its cost and health effects, but we are not comparing it with another health technology or intervention or health program, then it is not an economic evaluation. It is either an outcome description, cost description, or cost outcome description. However, there will be certain type of analysis which compares two alternatives, but either only in terms of cost or only in terms of health effects. Now, if such a comparison is done only in terms of cost, it is called cost analysis. See, now there are two programs which are compared, but only in terms of their cost. So it is called cost analysis. Similarly, if it is only done in terms of effectiveness, then it is called effectiveness evaluation. And I would like to recall here again the definition of economic evaluation. In the initial slides, we have learned that economic evaluation is basically a comparative evaluation of two or more interventions in terms of their costs and health effects. If two interventions are compared and both cost and outcomes are compared, then we call it cost effectiveness analysis. So that was all about economic evaluation and its different types. Now let us quickly see that how we interpret results of the economic evaluation. And if you are clear about the discussion so far, I'm sure you are having this idea in your mind that there is now ultimately we will get the health effects in a particular unit that is generated with a particular amount of money that is spent, because we are ultimately comparing two things in terms of health and their costs. So by spending a unit amount of money, this much unit amount of health we are generating. When we call this, we call it cost effectiveness ratio or CER. So what is this cost effectiveness ratio? This cost effectiveness ratio is basically what is the cost per unit effects that are generated out of one intervention. Lesser the amount of this cost effectiveness ratio, in other words, lesser is the cost of the same amount of effects that are generated, better is the intervention, because by spending lesser amount of money, we are getting more health effects. So lesser the value of cost effectiveness ratio, better it is. But when we do this comparison for two things, more than this cost effectiveness ratio, we are interested in something else that is called as incremental cost effectiveness ratio. That is basically difference of cost divided by difference of effects. And it is basically the additional cost of rolling out one intervention, of generating one additional unit of health gain in the population if we roll out our program A in comparison to program B. And the interpretation is same. Lesser the value of ICER, more cost effectiveness, more cost effective it is. Suppose we have done an analysis and we found the value of ICER as 1 lakh rupees per query gained. Now, will you term it cost effective or not? It is quite confusing because there should be some benchmark. For example, when we appear for exam, there is a cutoff that more than 36% or only those scoring more than 50%, they are declared pass. So this 1 lakh rupees per query gain, shall we call it cost effective or not cost effective? Pass or fail? We need some benchmark for that. In economic evaluations, such a benchmark is called cost effectiveness threshold. For any economic evaluation, if the value of ICER is lesser than this threshold, we term it cost effective. And traditionally, the WHO guidance had been that if the value of ICER is less than per capita GDP, you should term it as cost effective. And if it is more than that, up to 3 times sometimes they say, but later on they reverse this guidance. So the thumb rule was that if for any intervention the ICER is less than per capita GDP, we used to term it cost effective. And the underlying philosophy is this: see, what is one QALY? That is 1 year of full health. And what is per capita GDP? That is economic worth, that if a person of a country works for 1 year, that he will generate. So if the value of ICER is less than per capita GDP, which means that by spending lesser than that, the lesser than what this person will generate, we will be generating 1 full year. And in that 1 full year that is given to this person, he will actually generate the economic worth that is equivalent to GDP. So our expenditure is less, but our gain is higher. So we term it as cost effective. So traditionally, this interpretation of ICER is done in terms of this GDP per capita. But there have been certain criticism for that also, that we cannot measure that in our health or the benefit that have been imparted to the patient only in terms of rupees. So there are different approaches. Ideally, we should go and ask people that this much amount of health benefit, if that is offered to you, how much you are willing to pay. It is called assessment of willingness to pay. So for one query, recently HTIN conducted this study, and now the outcome paper is also accepted in Value in Health. That will soon be in public domain. That what should be that benchmark, or what should be that value of threshold in eyes of Indian population, so that we can term any intervention cost effective or not cost effective if it is lesser than that or higher than that. So that's how the outcomes of economic evaluations are measured. So the last part is, now I will take only a couple of minutes, that how practically these concepts are applied in India. And I'm sure in the subsequent lectures, these things will discussed in detail. So how it all started, that in 2012, in our 12th 5-year plan, there was a mention that all the healthcare interventions which are part of public health programs, we should assess their cost effectiveness. And in 2017, in Department of Health Research under Ministry of Health and Family Welfare, there is this institutional structure that was created known as Medical Technology Assessment Board, or MTAB, which was later renamed as HTAB, or Health Technology Assessment Board. In 2020, there is a full-fledged office that was created known as Health Technology Assessment in India, or HTAIN, and it got a stature of a sub-scheme of DHR under 15th Finance Commission in 2021. But the landmark development is that in 2023, this HTAIN is elevated to the stature of attached office of Ministry of Health and Family Welfare. Attached office, like we have CGHS, like we have National Health Authority. So HTIN is also having that stature now. It is an attached office of Health and Family Welfare, and its mandate is to assess the cost effectiveness of all the interventions which are presented to it by different user departments. And these user departments can be government, the different departments of health ministry. They can be certain agencies who roll out publicly funded health insurance. For example, NHA can be there. Earlier, there used to be different state-specific publicly funded health insurance scheme. Their offices can also submit those topics. Let's see, these are the different different interventions. Which intervention should we include in our health benefit package? Then there is National Pharmaceutical Pricing Authority also. It also submits that. So now it is an attached office which answers all these questions which are presented to it in terms of cost effectiveness. I will not discuss the application part in detail because I'm sure the next speaker will be covering it in detail. That is application of HTA in India. So I will stop here. I will stop sharing my screen. And if there are any question or discussion points, then I will be very happy to answer.
Thanks, Dr. Gaurav. Very nicely explained. And as you rightly said, today's session is mostly dedicated on HTAs and modeling perspective, right? So we can take up a couple of questions, Fatima.
Yes, sure, sir.
But before that, I want to say, Dr. Gaurav, this session was really amazing with a lot of examples, lot of real-time examples, and the students must have learned a lot from it because you have touched that, the core of the practicals, what they should learn, like the examples of, cervical cancer, examples of, hemophilia and all. This is so amazing and mesmerizing for the students. I think they should get the maximum of this session, definitely. So thank you very much, Dr. Gaurav. This was amazing.
Thank you, sir. Thank you, sir. Thank you so much.
Yes, sir. So the first question is from Shakshi Soni, who says that thank you for the insightful, informative session, sir. I wanted to ask, how do economic evaluation of diseases which have many treatment options available in the market? How to do the economic evaluations of diseases which have many treatment options in the market?
Yes. So what happens that primarily there should be two components, but if there are more components also, they can also simultaneously be considered. And while commenting on their cost effectiveness, there are certain, I mean, more sophisticated type of metrics which we call as extended dominance, which are done. In fact, in cervical cancer example that we discussed, there were multiple interventions. There were 3 interventions, and each of the intervention is having 3 different types of frequencies. So 3 multiplied by 3, there were 9 interventions in fact. So for each of this intervention, we actually calculated what will be the cost and what will be the outcome, and then we did the comparison. But when the options are more than 2, definitely it is not like 1 versus 1. Now we will have to compare the ICER of 1 with many other things. So here comes the concept of dominance and extended dominance. So with the help of that, we try to do that assessment. And I'm sure if modeling is today's core topic, then in subsequent lectures it will be explained. But it can very easily be done. It is not something like that. If the treatment options are more, the economic evaluation will not be solving our problem. No, it is not like that. It can very well and very easily solve our problem.
Yes, sir. The next question is from Akansha Verma, ma'am. Thank you, Dr. Gianni, for such a wonderful and easy to understand presentation. Since you're greatly involved in the Indian HTA, I would like to understand from your perspective, given India's mixed health financial structure, how realistic is to adopt the CEA CUA findings for national reimbursement or price negotiation decisions?
Thank you so much for this very good question. In fact, a black and white answer to this question is not possible, frankly, because there are different policy players which are involved when where to allocate the money or which health program to fund. But since its advent, HTIN has been involved in saving enormous resources. So with whatever limited capacity with which it started its operations, it tried to answer questions of different user departments. And one of the prime beneficiaries that is more important to the question that you have asked, that is National Health Authority. Because this HTIN was established just a couple of years before PMJY was launched. And when PMJY was launched, there were two primary questions. One, what should be the construct of health benefit package? For example, which all interventions should be included in PMJY scheme, that is Ayushman Bharat Pradhan Mantri Jan Arogya Yojana scheme. And the second question was that if an intervention is included, what should be the reimbursement rate that healthcare provider should be getting? For example, if there is some gallbladder surgery, cholecystectomy. So if a cholecystectomy is performed by an hospital, how much money it will be getting from the agency that, look, I have done this surgery free of cost as it was PMJY beneficiary. Now pay me 10,000 or 20,000 or 30,000. For that, we need to have accurate estimates of health system costs of delivering that intervention. That actually when such an intervention is conducted, how much does it cost? And for that, HTIN conducted CHSI study, that is cost of health services in India study, in which almost 70-80 hospitals across 9 states of India, primary costing exercise was done to identify that what are the actual resources which have gone into different type of interventions. And on the basis of that, those PMJY reimbursement rates were revised, because first there was the first component of HBP manual, or the first component of the HPV master that was released, which was subsequently released. Now we have HBP 2022, I guess, which is the latest version. So there are 4 revisions which have taken place so far, and in all the revisions, HTIN has played enormous role by providing estimates of cost of undertaking different types of interventions. Although from the point of view of economic evaluation, it tried to answer only one aspect, that is cost, but still it saved enormous resources. The second thing, that is which all packages should be part of this main health benefit package. For that also, especially with terms of oncology care, a lot of questions have been asked and many of them have been evaluated. And for example, there is one breast cancer drug, that is trastuzumab. And initially in the health benefit package, there were 6 cycles of trastuzumab. Those were a part of health benefit package. So if a PMJY beneficiary suffering from breast cancer patient, suffering from breast cancer, if he goes into such a empaneled facility and gets the treatment, only 6 cycles are given to that. But from healthcare organizations also and from patients also, there were repeated demands which were submitted to National Health Authority that more number of cycles should be reimbursed. At least 1 year of treatment should be reimbursed. Then an economic evaluation was done in which 3 alternatives were compared: the current 6-cycle regime, 3-month regime, and 12-month regime. And it was found that after 3 months, it is not worthwhile to give, because the health benefits that are imparted to the patients, they are relatively less as compared to the additional cost. So National Health Authority increased the reimbursement from 6 cycles to 3 months, but it said no to the original demand of 1 year. And in this way, National Health Authority saved almost 416 crore rupees. So that's how it actually helped different reimbursement programs in different ways to save precious resources.
Sir, the next question is from Mirza Aminur Rahman. Sir, since India does not have a clearly defined willingness to pay threshold, how can we interpret or justify that a new drug is cost effective under programs like the Ayushman Bharat?
Okay, again, a very good question. And till the time we don't have a specified willingness to pay threshold, we can continue to use that one-time GDP per capita threshold, because in the reference case for conduct of economic evaluations in India, it has been mentioned that we can use this one-time GDP per capita threshold till the time we don't have the empirical estimate. But now, as I have mentioned, that Department of Health Research has rolled out a nationwide study, and the estimates are also accepted for publication last week in Value in Health Journal. So the article is currently in production, and it will be out in almost 15-20 days. After that, we can use that threshold. I mean, I will not be sharing the finding per se, but it is almost similar to one-time GDP per capita. So till the time that thing is not there in our hand, we can continue to use one-time GDP per capita threshold.
Yes, sir. The next question is from Bala, who says, "How?"
Fatima, maybe one.
So sorry.
me.
Yes,
sir.
I think both are saying the same thing. Let's move ahead to the next speaker because they are waiting and we are already 20 minutes late for the.
Sure, sir, sure, absolutely.
Yeah, so the rest of the questions we will, we'll take and we will email to Dr. Gaurav and we will, get the
I'll be
answers for
happy
all
to
of you
answer.
guys.
Yes.
Okay, thank you very
Thank you
much.
so
It
much.
was an amazing
Thank you.
session, Dr. Gaurav. See the
It was
amount of
really
questions.
amazing. It was really amazing.
Thank you so
Yes.
much for
Yes,
inviting me.
it
Thank
was
you.
really
Thank you.
amazing. Thank you.
Thank you, Dr. Gaurav.
Yeah. Thank you once again, Dr. Gaurav Jayani, for sharing your valuable time and expertise with us today. We truly appreciate your contribution to this conference. Next, we move on to a hands-on workshop titled Case Studies on Application of CEA and BIM in India. This session will be led by Mr. Murtaza Stationwala, Manager, Market Access, Value and Evidence at Pfizer. Mr. Murtaza Stationwala is a Manager, Market Access and Value at Pfizer India. He has extensive experience in health economics and outcome research, reimbursement strategy, and patient access programs with prior roles at Path, AstraZeneca, and Eli Lilly. His work is focused on value dossier development, innovative financing, and expanding access to essential medicines in India and other low and middle income countries. He has also published academic papers and op-eds on health access, bringing thought leadership to the field. Mr. Murtaza brings deep industry experience in pharmacoeconomics, pricing strategy, and market access, and today's workshop will focus on real-world applications of CEA and budget impact models within the Indian context. Before we begin, I would like to remind everyone that we'll have a Q&A session after this talks. Please keep your questions ready and get ready to explore practical examples and learn how these models help inform reimbursement and policy decisions in India. Please welcome Mr. Murtaza Stationwala. Over to you, sir.
Thanks, Fatima. That's so kind of you to provide such a good introduction. Thank you. Before I would jump into the conversation, I would just like to set the context for the discussion. And now for that, it's if you can provide the mic access to the audience, I just have a high level question. Like, why do you think, and here I'm talking from market access practice perspective, so from industry perspective, why do you think cost effectiveness, BIM, cost utility studies are required? What do we want to really achieve with that? Any guesses, any wild guesses? If my mic access is not available, you can type in the chat as well. Maybe a couple of words, one word answer. What do you want to really establish with such efforts or such studies? Nope.
Please
I thought,
answer. Yeah.
Resource limited. Okay. Fair enough. Akanksha. Anybody else? Okay. Best allocation for resource allocation, drug in cost. Okay. If the drug is cost affordable, so that everyone could avail the product. Okay. Access 3 A's. Awesome. If you could spell Krishita 3 A's for the group's benefit. Better treatment in better cost. Awesome. So maybe broadly what I sense out of all these comments is the range of population we can reach, or as we call it, access, and B, if our drug is actually affordable or in economic sense makes a good proposition. What we generally call in market access practices value, right? And if all these comments put together, I'll have to give it a one word to define that. That would be value. What value your drug brings into the ecosystem, right? That's what we are trying to actually, in a way, assert through these studies. In a way, help government to, or any payer for that matter, even if it's for out of the pocket payer, to establish what is the value this product brings in. And a very high level example, which is not practically relevant to our discussion, but why do you really want to establish the value? A, to, because it's a drug, right? It's a drug. It by its nature will have clinical aspects to it, but those clinical aspects will have some other values linked to it, which can be economic values, which can be social values, humanistic values, right? And these things does not really come out very uh, openly as it happens for other products. For example, if it was an IT industry, these things are very easily relatable for a patient or for a prescriber. It's a, your product does some certain level of clinical it has ADME profile, it has toxicity level, those things are there. But how does it impact a patient's life, or how does it impact the overall society? This is very hard to establish in health perspective. And that's why this entire field comes up, which is known as health economics, right? And because the way drug development has advanced in past couple of years, what has essentially changed is various routes or mechanism of actions have come in. And hence to achieve the same outcome, for example in diabetes, to achieve basically to sustain blood glucose level, there are various routes. People are addressing it through kidney, people are addressing it through insulin, people are directly providing insulin. At the end of the day, they are trying to manage the blood glucose level. But how do you pitch one product versus the other? Then comes the humanistic value to it, social value to it. But these values does not come out very clearly if you discuss the product alone. And that's where you need to have certain scientific benchmarks, certain scientific methodologies to establish that. And this brings in the entire concept of health economic outcome research, where you want to establish clinical value of the product and its impact on other sub values to it, which can be humanistic, social, anything. For example, polio vaccine. We all know that polio can be debilitating. Polio will have direct impact on the person's life. And as a country, we decided that we really want to curb down polio. For that, we had a product which is polio vaccine, which has a clinical outcome that it prevents polio. But how does it impact the society? The person who is definitely infected with polio virus will have limited access to education, will have limited access to opportunities. So that impacts the person. If the person does not excel pretty much in his or her education, then that impacts society. And once that this person comes to an adult age, where the person would have been very productive to the country, but because of polio he or she is not able to do that, it impacts economic aspect of the country. And all these things put together will not come out very clearly when you discuss a polio vaccine to the doctor, unless you have published evidence for that. And that's why health economic studies are relevant. uh, Again, because if you look at the access perspective globally, there are four core payers, right? We have four models. I have listed it on the slide for you to actually go through it, and I'll share the slide deck also with the team to share it with all of you. But why I'm saying this is because I don't want to spend a lot of time on discussing these models, but this is to set the context. Majorly, there are four type of payers. Either a country says that state is responsible for your health, we will pay for your health, we will pay to keep you away from diseases. In case you get ill, we will help you to get health access and get cured or treated for that disease. Now state can do it at two levels. One is they say that the tax that we collect, we will pay that tax to to public hospitals. You can go there and get access to your health, which is typically the model we call it as beverage model, which was given to the world by UK. And because at some point in time India was also colonized, we have this model deep rooted in our system. The other is national health insurance, which in the last session we got a very good view of. The best suitable example for that is Ayushman Bharat, where government says that we will insure you. You can go to any facility, get treated. We will pay for that. Now, how much they will pay, whom all they will pay, that is a different discussion. There is the other flip side of it, where patient or the organization or the payer pays privately. This is generally done through insurance model, where wherever you are employed, your payer deducts some premium charges for insurance. They also put in to the kitty from their pocket, and you are typically insured for any health events, which is Bismarck model, which also came from Germany. The last one, which has always been around in this universe, is the out of the pocket reimbursement, out of the pocket availing your health access. So if you fall ill, you are responsible for your health, pay for it, get cured. Or else if there are any untowards events, you are responsible for it. And India being India, it's very diverse, it's very representative. We have all these models in our system, and this makes India uniquely different from the global access market. And that's where to all the people who want to be market access professional or who want to be in public health, this is what should excite you. Because if you work in any of the other developed or LMICs, developed countries or LMICs, you will majorly at the max have one or two models to work with. India gives you access to all the models, and you will have a chance to solve for crisis. You will have a chance to solve for all the problems all these models have. So, and this is typically what excites me to work in India the most. Now, zooming in a little bit more on India, India typically has four big public payers. And again, I'm focusing more on this because health economics has to do a little bit more with government aspect or the public reimbursement aspect rather than private aspect of it, at least in initial phase. And as a country develops, advances, both with private insurers and even at the out of the pocket level, health economics has a role to play. But if you really want to prioritize something, public health should be the domain if you really want to excel in health economics. And typically you will find federal accounts, which include CGHS, army and railway. It is nothing but kind of employment based insurance that the government provides to government employees. And the names are self explanatory. If you work with army, you are covered under army programs, which is DGFMS. If you work with railways, you are covered under railways health insurance, and CGHS is for central government employees. Because these are employment based and these people really work for uh, very crucial cause of the country, be it army, railways, or even central government employees, they are given 100% access. That means they are fully covered, their family is fully covered. And government really takes extra efforts to ensure that the best of the services are provided to them. That's why at the right column of the table where procurement considerations are charted out, you will see these accounts are value oriented. Put together, it does not cross, let's say, 12 to 15% of our population. 12 to 15% of our population put together. But since they are value oriented, they become easy accounts to crack from innovation perspective, because they really value your product. And because they value the people who are getting benefit out of these schemes, they want to provide the best. Then comes ESI, which is typically the biggest employment-based insurance globally, right? And here you will have to appreciate the difference between federal accounts and ESI. The beneficiaries, here the beneficiaries in ESI are those people who are making less than 25,000 rupees in a month in organized sector. So that means that typically they are not well to do, they are not the most influential cohort of the country, and in contrast, in federal accounts, these are the most influential people of the country. So basis this, the kind of coverage they get, here they are getting 100% coverage in terms of access to health, but the kind of coverage they get in terms of healthcare facilities is not that great. Innovation is still available in these accounts, but it takes a little bit more efforts and a little bit more time to get access into the formulary, because they are ROI focused. Why? Because it's an insurance program. Federal accounts work on assurance model, ESI works on insurance model. Assurance is to say that government will take care of you. Insurance is to say that let's employer and employee pays something for the premium, and the insurer will take care of your health. And when an insurer takes care of your health, they will definitely consider ROI as one of the thematic areas of their entire business case, right? Then comes state health schemes, which is your typical beverage model, where government says that we want to provide access to the entire population. However, government also prioritizes BPL cohort of the country, and also because these are a little underprivileged, they would also want to have access to the cheapest or the most affordable healthcare solutions. Hence, these cohort typically goes to state health run, I mean DHS or DME run programs. Then comes PMJ, which is a national health insurance body, which wants to cover the maximum population. So here the concept of UHC comes in. The main agenda of PMJ is to provide universal health coverage. So for them, the more people are covered under the ambit of PMJ is a success. At the same time, they are budget conscious because there is a kitty linked to the per family budget. So typically it's 5 lakhs. It changes for some population cohorts, but typically it's 5 lakh per family. So they will have to prioritize healthcare solutions that comes under this budget. And why the last column of this chart is important, this gives you perspective when you speak with these accounts, what is their consideration and how you will have to pitch your value or the value of your product to these accounts. This gives me lever into the next slide, which is where I think first and the last column is of the crux. If account is cost conscious, what they would like to hear, they would like to hear how is your product cost effective. To say that we already have one health technology available with us, why do we need to switch to the newer health technology or the drug you are suggesting? You'll have to justify every penny of additional investment. And again, if you could correlate it to the last session, this is where incremental cost effectiveness ratio comes into the play, where you say, yes, you are investing, let's say $10 more. Does it provide you enough incremental in terms of quality of life? If yes, then this product should be included in your formulary. And if not, then probably the organization should work on the costing if feasible. Then comes value oriented accounts like federal accounts, where they want to provide the best of the care. And to give you context, these accounts are typically those accounts which even takes extra effort to import the products which are not available in India under an inpatient program. So, for example, if one patient is diagnosed with a cancer which has a treatment but not available in the country, they get it imported. And getting it imported is to say that it is available in developed countries where you will have to pay probably in euros or dollars. So they are willing to invest so much for health, right? And what would you like to show them? You'd like to show them the benefit of the product. So typically a cost benefit analysis will go better with these accounts. And more often than not, it is even not required. If you are able to communicate your value without a model here, that saves your cost. But if really you'll have to justify the product, if it's such a big change to the overall medical practice in this account, then cost benefit analysis might help. But then comes budget limited or ROI focused accounts. That's where again, if it's a budget limited account, you will have to not just establish the cost effectiveness of a drug, you'll also have to give BIM model to say that this is cost effective. But if you input this product or this health technology in the ecosystem, the budget is going to change by so much, which in long term has a potential to ROI in terms of other values. If you are able to establish that, then the chances of getting access is higher. And for an account which is ROI focused, again you'll have to do budget impact model to show that in short term, if you are incurring more cost, does it provide you better economic sense in long term? And probably the way to do that would be you'll have to do a cost benefit analysis first to show that the product is beneficial, and then club it with budget impact data, right? I'll take a pause here before I go into the actual case studies to see if the context that I wanted to share, because next 3 slides will sum up the entire discussion. But that would only be helpful if I've been able to communicate why it is required. So maybe I'll stop sharing my screen for a bit and see if there are any questions now.
I don't see any questions, Murtaza, at this point in time, but I would
Yeah.
encourage people, if they have anything, please type in the chat window.
Why I want you to be very precise with your ask, because this is going to bridge the entire conversation. Do you anticipate
It is
India
one question.
towards a dominant model? A very, very valid question, Priyanka. And it will always have mix of the pairs, but definitely one pair will be dominant in the future, which is going to be national health insurance. Because that is also a mandate from UN perspective. If you look at the global trend where universal health coverage is growing, that is growing under national health insurance. And also government at this point in time is focused, and that's why you see a lot of investments being made on HTAIN, a lot of investments and prioritization been given to think tanks to help develop a model that could be applicable all across, because this is going to cover the maximum population. And even if you look at the current status, UHC under Ayushman Bharat covers around 40 crore people. And the kind ideally 100% of people are covered under state health insurance or a state health model. But if you look at real world data, 9%, about 9% of the population actually avails their healthcare from a state model. So as we speak, probably PMJ is already dominating the landscape. But because it is still in its nascent stage, more and more health technologies are being infused or injected in the system. The relevance of PMJ is going to increase with the time. But if you purely speak about the access or the reach, PMJ is already dominating it. How can we design one economic evaluation model and truly represent the cost? Again, Mirza, I mean, I think we need not do that as a market access professional. And here I am taking a specific industry stance on it. Why do we need to have a same model or universal model? As long as all these models cater to their beneficiary at the best, we can also sustain with it. And again, this is not from public head or policy head. This is coming from access perspective. If all these models can be efficient in their own ways of working, if these models can be more progressive, and that is going to happen as the funding increases in all of them, we need not have to have a mandate to uh, adopt to one model per se. How they see the costing of different healthcare services. This thing, Akanksha, I'll definitely take it in my upcoming slides. So, and please feel free to come back if you feel that the point is not addressed. So, around your question, do you think India will be able to adopt a common or? Okay, I think we discussed that. But ironically, in India, out of the pocket is 48%. Ironically, this is the real world fact that we will have to definitely live with. But if you look at it, the essential services that people were availing in out of the pocket versus probably 10 years back versus now has changed. Best example is maternal health, and also in cancer care. Typically, when I say 9% are only availing state health care for access to health, it is not true for maternal health. It is also not true for cancer care. So people, at, as and when people get more aware about the access landscape of India, their health literacy increases. You will see people migrating towards public healthcare. They will definitely prioritize for what kind of disease area, for what kind of services they want to prioritize public health versus private health. But yeah, 48% is out of the pocket expenditure. Still, this is not representative of all the therapeutic area. Curious to know. I mean, again, Priyanka, this is a very relevant question, and that's why you see that the investments that are made in PMJ or the entire NHA program, a lot of that is going to HWCs, where access to the last mile person is being ensured, and this is done through telemedicine or digital health initiatives. Again, it is nascent, but it is definitely growing, and that will play major role with the advent of more and more innovation. And probably the best example is how QRAI has been able to do it for lung cancer space. If a person is getting x-ray for chest x-ray anywhere in Rajasthan, inadvertently Cure AI is being applied to identify or predict uh, potential of that nodule to turn into cancer in long term. So the person might not be knowing that the health access is reaching to them, but somewhere some machinery is working. So it would be more evident, it would be more at your face probably in the future, but it is already happening. I think looking at the questions I get is just that people are in the conversation, and I'll come back to the couple of case studies that I would like to discuss. Sharing my screen again.
Yes, it is visible.
Yeah, nothing. So I'll take example of cost benefit analysis, and again, this is to put in the perspective where it is done and what impact it has been able to drive. JE, we all know Japanese encephalitis was never considered as one of the crucial areas to work in public health in India, although it was always an endemic or severe concern in public health for pockets in UP and Bihar. So government did a small pilot in 11 endemic districts, and probably the program would have died there unless this cost effectiveness study or cost benefit study would have been done back. The cost benefit analysis was done in retrospective, and it was found that internal return rate on the investment was 291%. That means every penny you invest, you get 291 penny more. right? And I mean 2.91 times more. So that means that people were able to back calculate benefit of the program, and this was published. How it impacted the system? Bill Gates came to India in I think 2017. This study was published in, I mean, retrospective analysis was done for program which was done in 2005. The study was lying somewhere, and in one of the conversations, UP government pitched the idea to Bill Gates to fund the program. Bill Gates actually agreed to fund the program in 2017, and now we are almost seeing 9 to 10 years of this funding being actively infused in the system. There is an up and running program for UP and Bihar on vaccination for Japanese encephalitis. I'm not saying that solely because of this study it happened, but anybody who is in the group is mature enough to appreciate that if Bill Gates is funding something, or else if government is asking for funds through Gates Foundation, they would definitely do it basis evidence. And I'm very confidently telling you this publication played a monumental role in that. So you see, even if a foreign foundation is providing funds for development in India, they would somewhere want to see every penny invested, what is the return that you are going to provide back. And the reason is they will also have limited kitty. They want to prioritize where to fund, where not to fund. And if such publications are done, on such evaluations are done on regular basis, this will open up more avenues, both for internal and external foundations, donors, payers to invest in public health. And you'll see the benefit of it. And I think a lot of publications are now made on basis the 10 years of the program to talk about the impact it has driven in UP and Bihar. The other bit is cost effectiveness. Again, I know everybody here knows what hemophilia is, but if I have to give a brief about the medical practice for hemophilia, 5 to 6 years back, pre-COVID era, if any person who was with hemophilia got a bleed, they would have to go to the nearest healthcare center or hemophilia centers, where they would get on demand therapy. What on demand therapy means is, once you are bleeding, you will be given factors, and these factors will help in reducing the bleed by coagulation. Now, why? And this was definitely beneficial back then, but there were definite challenges with that. First of all, when a person is hemophilic, even if they are the severity is medieval or high severity, moderate or high severity, the bleeds not necessarily happens in arms, legs, big muscles. They can also happen in intracranial region, and if that happens, it can be fatal. So by the time a patient could visit to these centers, get the factors, it could lead into the fatality. What emicizumab did is they they moved the regime from reactive to prophylaxis, where uh, injection is to be given on certain duration, weekly, monthly basis, and daily basis also at times, depending upon the severity and the doses. But the chances of bleeding reduces, and definitely this was a costlier therapy. If you look at the per vial cost of emicizumab versus the factors. But what Roche did then was to come up with solid evidences to clearly showcase, if you invest on prophylaxis now, the cost in prophylaxis versus the cost in overall disease management, if it's on demand therapy for hemophilia A, in long term it's definitely coming out to be positive. ICER was positive, and this was then infused in a couple of DHS run program. It was also pitched in NHM through PIP. However, the fundings were not allocated in PIP, but it came into the state formulary through DHS route. And these treatment, emicizumab is now available in multiple states across India for hemophilia patients. And again, this is to reiterate that cost effectiveness study had a role to play, but it was not the only lever. The communication of this needs to be pushed to the various stakeholders with the right intent, with the right voice, and then things changes. And now you see that a state like Kerala, they provide 100% access to emicizumab for hemophilia A patient, and in couple of states, population which is under 18 population is prioritized with emicizumab prophylaxis. So if you are able to convince, and again this is to address with one of the question that we had earlier, what if there are multiple therapies available? There were multiple factors available, EHLs were available, basis the shelf life, basis the nature of the product, various options were available, but emicizumab was able to establish its value at right cost. So this is how things, if put in right perspective, changes the entire conversation, changes the entire medical access practice. And then comes budget impact model. And if you could recollect it with my initial slides, where I said that cost effectiveness is one bit. You are able to establish value of your product. You are able to say that every penny incurred on this therapy brings on some qualitative or quantitative benefits. We measure it and we say that this is cost effective. But if you are a procurement manager who has a limited kitty, for example, if it's for cancer care, and to take example of Tamil Nadu, in TNMSC for specialty care, there is a specific budget allocated for specialty care. There are various products which are being included in EDL, which comes under the SDL category, which is super specialty or specialty drug list. Which particular therapy is to be prioritized over the other? How do you do that? That's where you justify value through cost effectiveness. And then you also paint a picture of, if you invest X amount of money on a particular therapy, in long term, what is the benefit you are going to reap out of it? There are n number of examples that really helped it, be it in the landscape of tuberculosis. One of the example that I would like to take here is dapagliflozin. And back then, when I was with AZ, we worked on it. We were able to establish budget impact with dapagliflozin's new indication versus if the same investment was made on the gliptins. Had it been the fate, we were able to have a longer patent, it would have been more beneficial for the organization. But since we were able to move that needle, we had a brief period of our patency where we enjoyed the business. But when the product went off patent, the real value of that communication came to the site. In various accounts, gliflozins, dapagliflozin to be precise, is a bigger product in terms of the value allocated versus all the gliptins put together. And for anybody who understands diabetes landscape or diabetes access landscape for last 10 years, they would know that there was a time where DPP4 inhibitors were ruling the market. To change that, you will have to have a narrative. And at times that narrative can be a simple calculation, which can be a BIA. And again, here it is important to reiterate that BIA per se is not as robust economic model or even economic model compared to cost effectiveness. But it's a sheer math. It's a sheer numbers game where you can establish what is the long-term ROI you can gain out of it. And government definitely sees value in it. And again, if you could put it in the perspective of Ayushman Bharat, where the kit is limited. Each patient or each family has only 5 lakh worth of kitty for their healthcare coverage. Government will have to identify if a particular product impacts the budget or not. If oncotherapy is included into the program, which is retailing in trade for 3.5 lakhs a month, definitely it is not going to get access, because a patient will only have access to 1.5 month of therapy, where they would just be recovering over the adverse events of the product. And after 1.5 month, the entire family is out of the coverage. That does not help. So from that perspective also, it was very important to have a specific budget impact model, which was standardized. And I think Dr. Pranjay and his team did a great work in doing that also. We now have official guidelines for budget impact model in India, and basis that further publications can be done and would be relevant to Indian context. Now, all the gyan that we had in the last 30-35 minutes, as a market access professional, this will only help you if you are able to prioritize, because all these studies also have a cost, and it is going to hit P&L of your project or your product, right? So to get the maximum out of it, you will have to prioritize which model for which payer, which will have the highest chances of access and better business potentials. So to do that, you will have to understand the payer, you will have to understand the product. For example, if we take example of hemophilia again. If Roche would have targeted other payers like PMJ, they would definitely not get coverage, because A, the product will be expensive, and the budget story that we discussed earlier. B, if they would have gone to federal accounts with it, which they did, but that was not their primary target. If their entire focuses or the resources were allocated to that, the access they would have unlocked would be very limited, because the population covered under these programs is very limited. So they prioritized states, which is a little tougher account to crack, requires a lot more time, a lot more resource, a lot more energy, but then yields higher results. So they prioritized states for hemophilia. When it comes to cancer care, most of the innovative pharma companies prioritize federal accounts, because they are value oriented. They want to provide the best care they could provide for their beneficiaries. So you will have to identify the payer. You will also have to see what kind of proposition you want to discuss with them, what kind of therapeutic area you are dealing with, and accordingly develop a model. And once you have developed a model, how do you communicate the value of it? That's the art of market access. You'll have to bring the best foot forward, the best values forward. You'll have to contextualize to the chair you are talking to. If you are talking to a
Um, he should join back. I think there's some technical error. Fatima, can you make Murtaza co-host? He's joined back.
He's already as the co-host, I guess, Ma.
He's already, we made him.
Okay,
Yes,
Murtaza, you're the co-host.
Ram Prashna, right?
No, Murtaza, he's still
Murtaza.
continuing his session, Dr. Ajit.
Question and answer as well.
Okay, he might
Okay.
do that.
Yeah.
No, he's co-host already.
Already.
Yep.
Okay. He has sent another. He's unable to unmute himself.
Yeah, actually, he left in between and joined
Yes,
again.
Sorry,
yes.
I joined with another device. My device went for reboot. But yeah, I think I was also concluding my slides. So if there are any questions, I'll take it.
Sure, Murtaza. Guys, please ask your questions. I think Murtaza people asked in between. So thank you so much
Thank
for
you
being with us
for the
today.
opportunity.
Yeah, it was a wonderful session. Thank you so much.
Thank you.
Thank you, Murtaza.
Thank you so much, Mr. Stationwala, for that insightful and engaging session. We truly appreciate your contribution to this conference. We now move on to a very exciting part of the morning, a session on HTA evolution in India. This session will be led by Mr. Ram Prasanna, Senior Director HEOR at Eversana, who will be sharing their insights on how HTA has evolved over the years in India, the challenges, milestones, and opportunities ahead. Mr. Ram Prasanna is a business leader in health economics and outcome research with over 19 years of experience in the pharma domain. At Eversana APAC, he leads the project management and client engagement activities for HEOR and RWE services. Prior to joining Eversana, Mr. Ram spent 19 years at various pharmaceutical firms, CROs, including the GSK, Sanofi, Baxter Healthcare, Frost & Sullivan, and IQVIA, where he focused on HEOR project management, client engagement, and business development. Mr. Ram's core responsibility is to provide actionable insights to healthcare clients based on real-world data in the process of facilitating informed decision-making at both strategic and tactical levels. Mr. Ram has hands-on experience in client liaison, executing market research projects, observational studies, data analytics, and assisting health economic project execution for global and local pharma companies across various markets like the APAC, US, EU, and Middle East regions. Mr. Ram's academic training includes Master of Science in Health Economics and Pharmacoeconomics and a Master of Science in Biotechnology. He has also completed a certificate program from an Indian premier institute, Indian Institute of Management in Sales and Marketing. It's going to be an insightful exchange of perspectives that reflect both policy and practice dimensions. Before we move into our next segment, I would like to remind everyone that we'll have a Q&A session, so please keep your questions ready. Please welcome Mr. Ram Prasanna. Over to you, sir.
Thank you very much and good morning, everyone. Thank you for the introduction, Fatima. It's a pleasure to hear very good things about myself. Thanks for a brief introduction. I'll just share my screen. We are used to Teams, so sometimes it becomes slightly difficult to adapt to Zoom.
There's a green button down.
Yeah,
Share.
I'm able to share.
Yeah.
Hope you can see my screen.
Yes, Ram. Make it full screen, please.
So, like everyone has already discussed about the topic, it's very interesting to know how HTA has evolved in the country and who are we considering as benchmark and what are the different kinds of studies that HTA has taken up is what I'm going to touch upon. So these are the brief agenda points, like the introduction. You have already introduced me, the key people involved in HTA and what are the objectives of HTA and the structure they function in. and the process that they usually consider for approvals or conducting or taking up studies for HTA analysis, and what are the different studies that they have conducted in the past, and few questions and answers. Yeah. So why HTA is required is very essential to understand. So according to WHO, every individual on the planet should have universal health coverage, and it is aimed to have by 2030 everyone will have universal health coverage. As part of that engagement, India launched PMJY, wherein they are trying to provide universal health coverage to most of the individuals. If you see the landscape of India, most of the individuals, at least 40%, nearly 30 to 32% of the individuals do not have any coverage, and most of them are covered under different coverage like the private voluntary health insurance or central government health schemes or ESIC and so on. So the remaining is covered by PMJY as of now. So by 2030, so the government is aiming to have this 400 million population also to be covered under PMJY. And if you see the private market, these are the most of the payers like the Star Health Insurance or HDFC, ICICI and so on. And most of them cannot afford these insurance packages, and hence there is a need for PMJY. So if we have to achieve UHC, the targeting the uninsured is the primary target for the government, and like I mentioned, by 2030, most of the individuals will be covered under UHC, and also the other target for the government is to reduce the out-of-pocket expenditure, and which they have already achieved by reducing from 60% to 50% in the last 10 years. And even the government is taking steps to increase the PMJY coverage for the families from 5 lakhs to 10 lakhs, and it is not yet implemented yet, but in the coming years, that is the target for the government. And even the budgets allocations by the government has increased multifold. In the initial years, it was 6,800, and as of now, it has increased to 9,000 crore in the current year. So how it evolved, I think many speakers have already covered this topic. Since 2012, the HTA was in the radar for the government, and gradually they implemented the HTA in India. So starting 2023, I think effectively the studies were undertaken, and many evaluations started happening in the country through HTIN. So as of now, most of the medical devices are under HTA evaluation, and even for pharmaceutical companies, HTA is taking initiatives for conducting the analysis. So under HTA, there are many advancements which are expected to solidify in the future. The HTA is going to help in making the decision making for health benefit packages, inclusion and treatment guidelines, pricing and quality and standards. While the initial versions of the health benefit packages were prioritized as by the HTA, but later the utilization rates and out-of-pocket expenditure and even the national cost studies are undertaken by HTA now. And we are also making databases like the NICE or HITAP of Thailand, because we are trying to not copy, but we are trying to work under the guidance of HITAP and NICE for HTIN. So we are taking all the learnings from HITAP and NICE for implementing the HTIN in India. So if you see in Asia Pacific region, the most talked about or the most evolved markets are Australia, South Korea, Taiwan, and Japan, which have introduced HTIN, and they have been very effective and very effectively used for implementing many public programs or even for the reimbursements in the countries. But if you see in India, we never had any HTIN, but recently we started including the public programs and also reimbursements, and even the private companies are looking at the cost effectiveness and budget impact analysis that are conducted, and even they are listening to these analysis outcomes and taking decisions on reimbursement for the products and including them into the formulary. So this is a revision again what everyone has spoken in national health policy was introduced in 2017. So in 2017 April, HTIN was established under DHR, and in the 119th Parliamentary Standing Committee in March 2020, the HTIN was introduced, but a working group of ministers in 2020 recommended the establishment of HTA agency, and since 2023 it has been full-fledged and is part of DHR, and the key people in the organization are the Cabinet Minister of Health, Sri Jagat Prakash Nadda, and Dr. Rajiv Bal is the Secretary for DHR, and Mrs. Anu Nagar is the Joint Secretary of DHR under the Ministry of Health and Family Welfare. So these are the key people of the organization who takes most of the decisions. So what are the key objectives of health technology assessments in India? To understand the HTA studies aiming at maximizing the health in population, reducing cost of expenditure, out-of-pocket expenditure, and reducing the inequity. To support the process of decision making in healthcare at central and state policy by providing reliable information based on scientific evidence, develop systems and mechanisms to assess new and existing health technologies by a transparent and inclusive process, and to appraise health interventions and technologies based on available data on resource use, cost, clinical effectiveness, and also safety. To collect and analyze evidence in a systematic and reproducible way and ensure its accessibility and usefulness to inform health policy. Dissemination of research findings and resulting policy decisions to educate and empower the public to make informed decisions for health. So there are different resource centers and across the country, and if you see, there are 4 different bodies that I have mentioned over here: Medical Technology Assessment Board, a TAC committee, and technical partners and resource centers, and a secretary who ultimately takes the decision. So there are different resource centers throughout the country which are spread, like the PGI Chandigarh, and we have several speakers from PGI Chandigarh today, and also AIMS Jodhpur, IIPH Gujarat, and so on. So these are some of the centers that we have listed over here. There are nearly 18 centers I have listed over here, and if you see the HTIN process, there are different board members who help in taking the decisions, and these are the board members headed by the chairman Vinod Kaul, who is from Niti Aayog, and these are some of the key members which I have listed over here, who are part of who are the board members and endorse the TAC outcomes and also recommendations. So if you see the TAC committee members, these are the names that I have found from the website. These might be updated, but these are some of the names that I have got from the website of HTIN. And how the process of HTIN happens. Once a government or a doctor from a government or central government agency from state government, if they have any new drug that they want to be included or a new technology to be included, they provide a request to the concerned authorities, and from there the prioritization of the topic happens based on the TAG committee meetings and also the board members, and based on which they take or identify the technical partners who will be working on this analysis or giving the outcomes of the studies, and they apprise the TAG committee members, and then a stakeholder consultation happens, because of which the recommendations by TAG, the board approves the technology to be introduced into the formulary, and then ultimately the state government or the central government starts procuring or implementing that in the formulary. So these are different books or manuals which are available that you can refer to for understanding the processes or the different HTI methodologies which are considered in HTIN. So there are different engagements which have been happening. One of them is every year the international conference for the HAIN happens in India. This year it happened in 2025 March, wherein they discuss on the policy briefs and the publications and so on. And also there is a HCA course which has been launched, which are taken by different students which are already engaged into this topic, and they have taken up this course. So this is a brief of the International Symposium on Health Technology Assessments, which happened in March 2025. The International Symposium was organized by Department of Health and Ministry of Health and Family Welfare in collaboration with WHO and Center for Global Development participated, and the Union Health Minister inaugurated the event. So there are different schemes in which the HCI decisions were considered, like the introduction of new health technology supports the center and state programs. Though 43 is a number that we have mentioned, but there have been several studies that have been initiated by HTIN, and support of benefiting health packages and revisions to Ayushman Bharat. And this is an ongoing process. This is not a one-time activity. And the procurement and identifying of cost-effective thresholds for different health technologies, and cost-effective and Make in India initiatives have been initiated through the central government based on the recommendations from HCIN. So these are some of the studies that have been published, and these are available for a review also, and you can download these studies from the website. These are some of them for medical devices, health programs, and diagnostic devices. There are several guidelines that have been published based on the studies that have been conducted by HTIN. There are drug studies which have been conducted by the HTIN, which have recommendations for cost effectiveness and inclusions into the formulary. And these are, even during the pandemic, the HTIN was very effective in advising the government to consider different diagnostic technologies to be considered into the formulary and for the approvals. So this has been already discussed by different people in the, and these are the this is one of the largest study which is conducted in India for the understanding the cost of health services in India and national costing initiatives. This was conducted for different specialties like the ENT, urology, CVTs, or orthopedics, OBG, and so on. And this study basically helped in devising the packages for the Ayushman Bharat, wherein nearly 842 packages were entered into the database, and are already considered in the for the reimbursements for different packages across government as well as some private hospitals. See, if you can see the health facilities which were considered were the district hospitals, private hospitals, and public tertiary care hospitals. And this is one of the largest costing studies which was ever made. And based on which the packages were approved, and there are different packages which was approved in different during the evolution of the HTA. So to start with, nearly in HPP 2, nearly 874 packages were approved, and now in HPP 2.2, nearly 920 packages are involved, and different specialties are already considered into the packages, and different additional procedures are already added into the packages. And this is the National Health System Cost Database, which is an online portal which uses the cost analysis, and which is helped reducing the Ayushman Bharat package by nearly 80 to 90% packages were revised in PMJY 1 to 2.61, 1 to nearly 2% rates were increased, and 18% rates were reduced based on the analysis conducted by HCIN. And this is one of the largest studies conducted in the world for EQ5D. And because since there are no utility values for the country, the government took initiative for conducting these studies, wherein the quality of life studies were conducted among different therapy areas, and nearly 2,400 interviews were conducted, and the utility values are going to be streamlined and in the coming days, and nearly 3,000 interviews were conducted as part of the initiative among different states in the country. And I think Dr. Gaurav has already talked about this point about which are the different therapy areas which are covered, and why this is really essential to have utility values, because the utility values for different therapy areas can vary from country to country, and having a utility value specific to India is essential to conduct the cost effectiveness analysis, cost utility analysis. And as part of this initiative, the utility values that will be derived from these studies will be used for the analysis for Indian population specifically. So if there are any questions, please do let me know. And these are some of the examples that the speakers have already touched upon, especially for the cancer treatments which are conducted. The cost effectiveness analysis and value-based pricing for anti-cancer drugs were implemented among different by the HTA agency for the benefit of patients, industry, as well as insurers and regulators. Nearly 42 anti-cancer drugs assessments were conducted by the HTA agency, and to assess the economic burden and the health-related quality of life among patients in India. So based on which the impact assessment for nearly 42 anti-cancer drugs were analyzed. Even the claims, the impact assessment of price regulation on claim amount for nearly 28 cancers were reassessed by HTAIN agency. This is one of the examples for CDK4/6 inhibitors in the treatment of metastatic breast cancer. Is the cost worth it? Which was analyzed. This is the cost effectiveness analysis and value-based pricing for anti-cancer drug. the implications for industry, insurers, and regulators, wherein the study main question was to understand the effectiveness of ribociclib and palbociclib as a first line as well as a second line option for the treatment of the HEGFR2 negative in metastatic breast cancer patients, especially in postmenopausal women in Indian context. And the resource center was PGI Chandigarh, which took up the analysis. And the cost effectiveness analysis was conducted with the societal perspective, wherein a Markov model was developed to estimate the cost and consequences of the metastatic breast cancer patients. The study compared ribociclib and palbociclib combination as a therapy as compared to fulvestrant monotherapy as a single agent paclitaxel and single agent capecitabine in Indian context for two different time points. The first scenario was as per the prevailing market prices of the drug, and the second scenario was as per the reimbursement rates set up by public financed national level health insurance schemes. And the outcomes were both CDK4 and 6 inhibitors are not cost effective in the Indian scenario, even if the costs were reduced by 95%. So they were not considered in the reimbursement. And the 78% reduction in the market price and 72% in reimbursement rate would make fulvestrant monotherapy as a most cost-effective treatment option for metastatic breast cancer patients was one of the outcomes for the study. And this is another example wherein Dr. Gaurav has already verbally discussed about this study. This is one of the landmark studies wherein the cost effectiveness of trastuzumab for the management of breast cancer in India was discussed earlier. This was a cost effectiveness analysis wherein cost effectiveness of adjuvant trastuzumab in combination with the standard chemotherapy was compared with chemotherapy alone for breast cancer in Indian context. Again, PGI Chandigarh was the resource center which undertook the analysis, and the paper is already published and it is available for review for the members. The methods and approach for the cost effectiveness analysis with societal perspective, and again a Markov model was developed to compare costs and consequences of treating patients with surgically treated HER2 positive breast cancer at for the patients who are above the age of 50 years with adjuvant chemotherapy or adjuvant chemotherapy with trastuzumab. So the results were very encouraging for the reimbursement, especially because the trastuzumab for 1 year, which was requested by the doctors and the state and the central doctors, was not cost effective, and hence the 1 year reimbursement was not approved. However, a 9-week cost effectiveness was compared, which shows that at least 9 cycles can be covered, and which effectively increased the effectiveness, means the management of the patients, and was later reimbursed for the patients in both central and state. Of course, though the SCAN decisions the outcomes are published and provided to the government as well as the state agencies, it is up to the discretion of the agencies to consider and put it into their formulary. So most of them, they take a decision based on the budgets they have, whether to reimburse a product or not. This is another example for bevacizumab as a cost effectiveness option for the treatment of advanced cervical cancer. So this is again was conducted by PGI Chandigarh, wherein the cost effectiveness using a disaggregated societal perspective. So Markov modeling was again considered, and data collected was based on the out-of-pocket expenditure and quality of life values. The health system costs were derived from previously undertaken costing studies based on literature reviews, and clinical effectiveness data was taken from the clinical study GOG 240. The comparators were paclitaxel and cisplatin, and the results were over the lifetime of a patient of advanced and metastatic cervical cancer. Treatment with bevacizumab resulted in a gain of 3.3 months life months and 1.55 quality adjusted life months at an additional cost of 2.82 lakhs as compared to standard chemotherapy alone. So incremental cost effectiveness ratio of 25.75 lakhs per one quality adjusted life year gained with using bevacizumab along with standard chemotherapy was not cost effective. And the cost of treating adverse events of this intervention is huge, as a result of which the drug is not cost effective even after reducing its price similar to the control arm groups, and hence it is not reimbursed. So the other programs which are managed by STIN are there are several programs which are undertaken. Like I already mentioned, there are multiple studies which have been taken up for linking HIV and FP services, cervical cancer screening strategies in India, screening of type 2 diabetes and hypertension in India, and improving adherence through tuberculosis medication regimen using tuberculosis monitoring encouragement adherence drive. And these are, especially during the pandemic, they played a very important role. And these are some of the activities which are in progress by STIN, scale up STA studies, prioritization of topics, and recommendations from the health assessments and implementation, increasing role of user departments and stakeholder engagements. And thank you so much for listening to me. And if you have any questions, please do let me know. Yeah.
Yeah.
Thanks, Ram, for the insightful presentation. Fatima, if you can read out the questions,
Yes,
please.
there is one question, sir, from Akansha Verma, ma'am. Thank you, Dr. Prasanna, for providing a deep dive into the HTA in India. Would like to understand what is usually the turnaround time from application to final regulatory approval of a healthcare technology or drug in India?
So it can take anywhere from application which is made by a state or a central government. It can take up to 1 year to 1.5 years for the consideration, and then finally assessment based on the priorities which are derived from the board members. So it can take anywhere from 1.5 years to 2 years for the consideration and analysis to be done. So I understand usually from discussions with some of the members in resource centers, it can take usually a scientist who has been assigned for a particular project. They have been given set timelines for completing a particular study, anywhere in the range of 6 months to 9 months for conducting a study and publishing the study. So once the is been considered as a priority till publication or giving a decision for reimbursement, it can take up to 2 years.
Yes. And sir, another question is, how do you see the next decade of HTA in India? Universal coverage integration, digital evidence systems, or a national reimbursement framework? Where are we heading to?
So the outlook is positive because starting from 2023, like I have already mentioned, there have been several initiatives which has been taken by HTA agency for considering and approving several technologies. So not just limited to the medical devices, even the pharmaceutical products are being considered. and digitization is going to be crucial for the evidence synthesis and platforms. So this is going to be positive, and the national reimbursement going to take several initiatives for reducing the time period for the reimbursement of the drugs. And if the pharmaceutical companies and medical device companies are going to take the initiative of conducting the assessments early during the early phases of the study, it can support quicker decision making and faster reimbursements of the product, and encouraging even the private insurers to consider the difficult and value-based medicine to be considered into the reimbursement faster.
Yes, sir. And there is one more question from Anjali Yadav. Thank you, sir, for such an insightful session. My question is there a plan to periodically update the value set as health preferences evolve over time with socioeconomic changes?
I'm sure this will be one of the priorities for the HTA agency. But as of now, I'm not in a position to give an answer to that, but I am sure it is a priority for them.
Yes, sir. Sir, I think that's it with the questions. Thank you so much, sir, for such an insightful session. Okay, yeah.
Thank you, Ram. Thanks for interacting with the audience and sharing your knowledge.
Thank you very
It
much.
was lovely listening to you. Thank you.
Thank you so much, Richa. Thanks for the opportunity.
No
Bye.
problem at all.
Thank you, sir. Up next, we have our final session for the morning, a talk on budget impact analysis, design, assumptions, and pitfalls, delivered by Dr. Loveleen Taneja, Principal HEOR IQVA. Dr. Loveleen brings vast expertise in health economics, modeling, and the real world data analytics. And in this session, she'll be walking us through the core principles of BIA, the assumptions behind it, and the common challenges to avoid when designing these analyses. Before we begin, I would like to remind that we will have a Q&A session, so please keep your questions ready. Please join me in welcoming Dr. Loveleen Taneja. Ma'am, over to you.
Ma'am, please unmute yourself. Let us know if you're not able to do so. Fatima, help na. Yeah, you've made her co-host.
Yes, now she's made the co-host.
Now I can.
Oh, great, ma'am. All yours.
Thank you so much. Thank you, Fatima and Richa, for this kind introduction. And let me share my screen. Please let me know once you can see my screen.
Ma'am, we can see.
Thank you. Okay, right. Today I'll be talking about the budget impact analysis. How do we do it? And assumptions and the main issues to be looked at. Now, during the morning sessions, various speakers have already, touched upon why we do a budget impact analysis. And as they correctly said, that it determines whether a drug is affordable or not. Whereas a cost effectiveness analysis looks at whether the intervention is giving you value for money or not. But what does affordability actually mean? Now, let me take an example of non-healthcare. Suppose on Diwali, you got, your relative gave you 2,000 rupees. You decided to go and have a nice meal. Now, the buffet at the local five-star hotel is costing 3,000. What does that mean? It's good value for money. They have a wonderful spread. They have different cuisines, gourmet. They even have sushi. So it's good value for money. But is it affordable? Where is that 1,000 rupees extra going to come out of? It might come out of your money that you kept as backup. It may come out of the money that you kept for commuting. So is it affordable or not affordable? And that's a question that majority of the payers also have to answer. So it goes beyond just looking at the cost of the new drug, and it looks at how will this drug actually be funded. Majority of the HTA bodies are asking for a budget impact analysis in addition to a cost effectiveness analysis, including NICE in England and Wales. You have the PBAC in Australia, CADET in Canada, even the US peers ask for it. There are a lot of HT agencies which actually ask for only the budget impact modeling, considering that a cost effectiveness analysis can still be considered applicable. If a drug is cost effective in US, it is also likely to be cost effective in India. But the budget impact analysis is very, very specific to not only the geography, but also the payer. A classic example that I give of the drugs which are cost effective and yet are not budget saving is a drug called Solvadi for treatment of patients with hepatitis C. Now, hepatitis C is a very severe disease, and usually the jaundice resulted in liver failure. Patients went on to require liver transplant, even got liver cancer, and the mortality was very high. The current drugs were not curative. Solvadi was the first drug which gave a complete the chance of having a complete cure. It had it removed the virus completely from the body in almost 95% of the patients. So it improved survival. And when the cost effectiveness analysis was done, it was found to be cost effective. But when they did the budget impact analysis, what they found was that this drug was simply could not be reimbursed. It was not affordable. In fact, the World Health Organization, as you see the example given on the screen, you will see that they said that if you were to treat only 20% of the eligible patients, hepatitis C patients, it would cover about 20% of annual drug expenditure in Italy. Now, to give context, this drug was launched at a price of $1,000 per pill. It was a 12-week course, and that costed around $84,000 per patient. It was launched at a slightly lower cost in Europe. I think in France it was about $50,000 or 41,000 euros. In Italy, when they did the cost effectiveness analysis, they found that it was cost effective. If you look at the results that I have given from the publications, even if the cost of therapy was taken as low as 15,000 euros, which would be roughly about 17 or $18,000 at that time, going up to 50,000 euros, it was still cost effective. The ICERs at the highest is only 13,540 euros per quali, which is well below the threshold. However, when you looked at the impact on the budget, coverage at 50,000, it was 56 million euros per year. Now, please remember, Italy's total healthcare expenditure in 2016 was only 149 million euros. Out of that, 56 million, that's huge amount. And out of that 149 million, which covered everything in healthcare, the medical pharmaceutical products were only at 31 million. So in fact, the cost of treating the hepatitis C with Solvadi was higher than the total healthcare budget that Italian government payers were spending on the drugs. And hence, what does a BIA help in? One, it helps in the pricing negotiation. Second, it helps the payers in evaluating what is their annual budget needs to be. Third, it can help in evaluating the year-on-year impact on the budget if a new therapy was to come in. And fourth, and most important, it basically tells you whether you can reimburse a drug or not reimburse a drug. And hence, how does it differ from a cost effectiveness analysis? As we discussed, the budget impact analysis looks at the impact on budget and affordability, whereas cost effectiveness would look at cost per outcome. The perspective in a budget impact analysis is mostly peer perspective or the budget holder, depending upon whether you're doing it for a hospital, you're doing it for a healthcare system, or you are doing it for a specific payer. Whereas in a cost effectiveness analysis, you can have a peer's perspective, you can even have a societal perspective, where you are including the indirect cost. Time horizon is usually shorter, 1 to 5 years in budget impact analysis, basically because new drugs are going to come in the next 5 years. There is inflation, there may be a change in budget, there's a change in the population, and hence these are more short term. Cost effectiveness analysis is usually long term. We say patient's lifetime. Yes, in cases of rare diseases or diseases with very high mortality, example oncology, in fact, the time horizon may be very low, 1 to 2 years also. However, it would be the patient's lifetime that we are looking at. What are the costs that we include? In budget impact analysis, it will always be the direct cost to the payer. It will exclude the overheads or any cost that does not change over the uh, lifetime or sorry, over the time horizon of the budget impact. Now, when we say direct cost to the payer, it also excludes any co-payments or any out-of-pocket payments on the direct medical cost that the patient may be making. Whereas in a cost effectiveness analysis, we would include all the direct cost, including what the patient is paying. Indirect cost may be there occasionally, depending upon the perspective. And usually you include all the variables in the long run. Another thing, and we will discuss this again when I talk about the cost. In budget impact analysis, you basically include costs which are changing due to the new intervention. If there is no change, then usually we do not include it in our analysis. Health outcomes as such are not included. However, if they uh, impact the budget in the long term, or they are, have a cost offset, or they result in us if they saving the money to the payer, in that case, they would be included. Whereas in a cost effectiveness analysis, health outcomes would always be included because in a cost effectiveness, you're looking at the clinical outcomes in the ICER, whereas in cost utility, you're looking at health outcomes multiplied by the utility value, and hence in a cost utility analysis, again, clinical outcomes would be included. Long-term health impacts are very, very difficult to include in health outcomes. Things like survival or any outcome which is going to happen, say, more than 5 years from today, those are difficult to include. Whereas in a cost effectiveness analysis, because we have a lifetime horizon, yes, these can be included. No discounting needed for budget impact analysis. Short term in cost effectiveness analysis, yes, it would be done. Whether the costs are only discounted or cost and health outcomes are discounted, that would depend upon vary from country to country. And output you're getting is the impact on the budget in budget impact, whereas in cost effectiveness, you're getting the cost effectiveness ratio. This is the basic structure of a budget impact analysis. The various parameters that you look at is the population, coming down to the target population. What are the healthcare resource utilization? What is the unit cost of each? And hence, what is the total cost of illness? We look at two scenarios, the current environment or the new scenario or environment. And hence, what is the difference gives you the impact in the budget. Now we will go through each step in slightly more detail. Your first step is that you need to define the target population. So you usually can adopt two methods. One is called the top-down method, which is basically that you know how many disease patients are there and then you try and get it. The second is the bottom up. I know this looks inverted, but this is actually a funnel which is used for a bottom up approach, which is the more common approach used, that you have the total population, you try and reach out to the disease population, include the eligible subgroup, and then the treated patients. When you're defining your eligible population, and this is based on again the local epidemiological data, you have to be very careful about how you are making it. You can have the prevalent cases if it's a chronic disease, incident cases if it's more acute or less than 1 year duration disease. Two things to think about here. One, are you double counting the patients? You can, if you are having especially prevalent plus incident patients, are you also applying population growth? Is your patient population growing beyond what is expected? So the validation or triangulation with published data is very important. Second thing is change in the patient pool over the years. There is population growth rate. Due to the new option, is there a change in the treatment rates? Is there a change in the diagnosis rates? Any change in the disease prevalence? Especially for infections, for you have to take into account that there may be an epidemic, pandemic, there may be an effect of vaccination, and hence the prevalence of the disease may also go down. Even the incidence may go down. Are there subgroups which are more relevant? Perhaps you're including both, but do you need to include that as different subgroups within your models? Are there split or differences in the treatment based on age group, disease severity, any comorbidities? There might be, gene mutations that are causing different subgroups. So your patient population or the eligible patient population should be aligned to the local treatment practices. Everything in fact in your budget impact modeling needs to be aligned to the local treatment practices. If there is no difference in the treatment, it can be included as a simple group. The major issues occurs that if we do not account for the change in the population that would occur over the years. Once we have looked at the patient population which is eligible, you define the parameters that you're going to be using. Whose perspective is it? Is it one pair? Is it two pairs? Usually, if there's a change in the pair, there would be a change in the population being looked at, because the total population covered is going to change. There's going to be a change in the total budget of the pair. And hence, occasionally there might even be the change in the cost. Or the treatments which are being covered, and hence each pair would need a separate budget impact model to be created for them. Of course, it can be adapted because sometimes only the cost may be changing along with the patient population, but it would need a separate model adaptation for each pair. We already talked about time horizon discounting. When you're looking at clinical outcomes, please remember that you can include both primary and secondary as long as they're significant. If they're non-significant, do not include those outcomes. Or if you're including them, put the value as same for both the treatments or all the treatments. An example that I've given here is, looking at, it's a visual example. Here, this drug is equivalent to placebo. So if I have to include, I have to make a budget impact modeling where I am including all of these drugs. I have to take care that this is improving the renal outcomes. I'm not sure if you can see, but this is last is the renal outcomes. This drug is improving the renal outcomes better than the GLP-1 RA. However, GLP-1 RA is better than DPP-4 inhibitor, which is equivalent to placebo in the renal outcomes. So if I have included the renal outcomes, I have to be careful that I am including the relative risk of improving that outcome or causing an adverse event or causing a complication based on the drug that I'm including. Usually, outcomes directly from individual trials should never be taken. You should take this from the network meta-analysis or any other meta-analysis that may have been conducted or you would have conducted it. Coming back to the outcomes, if there is a composite endpoint, you can take separate outcomes within the reported composite endpoints as long as again they are significant, statistically significantly different within each drug. If the outcomes cannot be converted into a direct cost, for example, there's an improvement in the say patient's state of mind or um, decreases the nausea, but that nausea was not being treated, then you cannot, there's no even if you include that clinical outcome, it is just an extra endpoint that you're including because it's not going to be converted into cost. If there is no drug treatment being given for a particular condition, improving it is not going to help. Similarly, there are certain outcomes where there may not be any treatment being given because there may not be any treatment. In that case also, there is no uh, significant there is no change in the cost and hence there is no need to include that treatment. Please do not double count the endpoints. If you have included, say, the composite endpoint, do not include a sub part of the endpoint as a separate outcome. Post hoc analysis, just be careful. Post hoc analysis is not to be taken in economic evaluation because it was never planned for. The trials that were conducted are not powered to detect any change. So even if the results were significant in post hoc analysis, we would disregard it. Once we have defined what we are going to do, we have defined the outcomes. The next is the cost of the treatment. So you define within each outcome, you would have defined that what is the treatment that needs to be given, what is the healthcare resource use for the disease with each drug. Resources where there is no change, again, does not need to be included. For example, diabetes example is something that is commonly been talked about. If I have a drug metformin, I have DPP-4 inhibitors, I have GLP-1, SGLT2. So I know that this patient has failed one line of drug. Now with metformin, I need to add another drug. If I'm doing a budget impact analysis, is it going to change the diagnosis of type 2 diabetes? No, the patient is already diagnosed. So I will exclude those costs which are not impacted by my new drug. And that's why I have the diagnostics in brackets. In certain cases, especially where there are targeted therapies, you have a gene mutation, there's a new drug which is targeting the gene mutation. Before this, the current treatments were given irrespective of whether the mutation is there or not. Now, the new intervention requires the test to be conducted, and hence here I'll include the cost of that additional test or diagnostic. The other costs that would be included are the drug acquisition cost, which is basically the price of the drug, whether you are including the retail price or the price to the payer. That will again depend upon the perspective that you are looking at and what is it the payer actually paying. The cost of administering the drug, monitoring cost, everything has to be annualized. If you are giving the drug for only 10 weeks, 6 months, that cost of 6 months would be considered for the whole year, and hence that is called annualized. Any follow-up visits, OPD visits, ER visits, rehospitalization, within hospitalization, whether it is inpatient, daycare, or a long-term care facility because the patient may have stroke, dementia. Any other treatments or procedures, cost of managing complications, comorbidities, any adverse events with each of the drugs, especially drugs like in oncology, where the adverse events cost may be very significant. Now, all of these unit cost, the major source would be the local treatment guidelines or databases. Drug costs are easy to get. For the resource cost, usually, we would either get them from any published guidelines or say the list that has been given by the payers. Or the second option is to conduct the market research with either the prescribers or the payers to get these costs. I talked about the healthcare resource use. Now, where does that come in? Now, this again can come in from a local RWE study. It can come from the treatment guidelines. In the event that if country-specific guidelines RWE study is not available, you may go in for a market research with prescribers, although it has a lower value than a RWE study or treatment guidelines because there would be a recall bias associated with it. Usually the issues that we face at this time is in the drug acquisition cost. I talked about, uh, uh, retail price versus the price being paid by the payer. Usually it's the price being paid by the payers. But in generic drugs, what do you do? Now, there are certain countries, such as England, where NICE has given that we will take the option with the minimum cost. But in a country like India, where we have hundreds of brands available for a single drug, if it's generic, with different costing, well, we have usually gone in for the average cost. Again, based on the country that you're doing, based on the discussion with the payer, is how you would decide which cost to take. Cost variations by payers would be there even in India. If I'm doing a model for CGHS versus say ESI, there may be a difference in the cost. ESI may not be giving the expensive drugs or maybe using a tender to purchase the drugs, and their drug cost may be very different from that of CGHS versus that of say military hospital. Well, this I have already covered. Now, when you're calculating the cost inputs, you have to remember that it is price per dose multiplied by the doses per year. So please do take into account the frequency of giving the drug, which may vary, and the average dose per drug, which would again come from your prescriber. Sometimes there are multiple doses available, and the share of the different doses may be different. In that case, you would be taking the weighted average of the dose. In case of device, remember that it is not only the cost of device, it will also be the cost of maintenance in that year. There may be a training cost available for use of a device, or if you're giving self-injection, then a certain training cost may be there. When we're looking at the administration cost, we're looking at the cost of equipment. For example, if it's a IV injection, then in that case, you're also looking at the solution that may be used for dissolving the drug, as well as the IV set that may need to be given, the cost of cannula, the cost of inserting a long line or a central line. The cost of healthcare worker, which may be physician or nurse. Drug reconstitution may be required in that case, the cost of a pharmacist, and there may be a need for a hospitalization. It can be daycare hospitalization or short term, or it can be inpatient hospitalization for 2 to 3 days, in which case it would be longer term. We've already talked about that co-payments or payments which do not change over short term, like the fixed cost of an infrastructure. Those don't need to be included. Cost offset. So basically, cost offset is nothing but what is the saving that we are able to see when a new intervention is coming in. Now, where does this cost saving come from? It may be because the new drug is being given. There is no cost of hospitalization. An example would be that in oncology, 5-FU is a drug which may sometimes needs to be given as a continuous infusion over 3 to 5 days. That needs hospitalization. On the other hand, you have a drug which needs to be given over a 1 hour infusion. In that case, it becomes a daycare, hospitalization. The cost has decreased substantially from 3 days to a few hours. 5-FU also has an oral formulation called capecitabine. If I'm giving the oral formulation, there is no need for any hospitalization. So the cost goes down. That is the cost offset that we are looking at. Perhaps giving this drug leads to no surgery, or take an anti-obesity drug. If the person is able to reduce weight to the required levels with the drugs, you will avoid the bariatric surgery. So that's the cost of procedures avoided. Patient has type 2 diabetes. You're giving drugs to control the diabetes well. You're avoiding the cost of getting the complications. A lot of time we have seen, and this especially happens in countries where you do not have robust data that has been published, that there is no local data that is available. Even the prescribers are not able to tell you, or the payers are not able to give you the data. In that case, we can use data from similar countries and convert it with the assumptions, and we will look at it that there is going to be uncertainty in that data, and hence sensitivity analysis needs to be done. But what happens is that how do you convert that data? Usually what people have done, suppose don't have a certain cost for India, and I take the cost coming from US. Now US may not be a representative country. So is there another representative country with a similar GDP as India, or a similar healthcare system as India? Perhaps a country from lower cost country from Europe may be more representative of India, right? In case you have it, you have to take this data from international. Please use purchasing power parity to convert that data. Do not use a simple conversion using exchange rates, else it will not be representative. And to reiterate, one of the issues that happens with budget impact modeling is that we cannot include outcomes which may be significantly impacted but cannot be converted to cost. In example, the cost or cannot be converted into a direct medical cost. Hence, the cost of improved survival does not come in. Current versus market scenario. So what you basically look at is, in the current scenario, what are the different treatment mix that are being used? When the new drug comes in, what is how the share of each treatment is going to change? Now, it may be an addition. That means that it is being used in addition to the current standard of care. It may be a replacement therapy. It replaces certain drugs. Or it may be a market expansion even. That means that because this drug is coming in, the diagnosis rates have changed. The patients are being diagnosed better, or the patients who were not eligible for treatment earlier are also now eligible for treatment. That's two ways the market expansion can occur. Another thing that you have to look at is the uptake curve of the medicines. Now, there are different ways to look at it. You can do an analog analysis of a similar drug. There can be a generic S-curve that is arrived. Sometimes market research, especially of the target product profile, is tested to look at what is the uptake that would be there, whether it's a slow, it's a fast uptake. If it's a new formulation, the doctors are already well aware of this drug and are willing to take it up faster. The main pitfalls when you're looking at the current versus new market scenario is that whether you have included all the relevant competitors, and this includes drugs which may be being used off label. If it is being used, it should be included for that patient population. If you're making the uptake curve very aggressive for a new intervention, then again, you know, it will be questioned because it takes time for the new intervention to be um, accepted, understood, and then used. Sometimes in things like market expansion, where patients who were ineligible are now also being included, there may be patient numbers would be dissimilar in the current versus new scenario. Patient numbers always need to be same. It should be included in the current scenario as patients with zero treatment, and hence you would look at the cost of the annual budget. So we have already talked about all of this. This gives you me the total cost of treatment for X number of patients. This is a new scenario. The drugs have the new intervention. Everything else remains same except the things which are being impacted by the new intervention, and you would get a total cost of treatment. This will give you the subtraction of the total cost from the current cost will give me the change in the total budget, which would also be divided into change in the budget year on year and change in the budget per patient treated. Reporting the results. When we're reporting the results, like I said, you would look at the current budget versus the new budget and segregate it by the type of the cost. So you have the AE cost, you have the drug acquisition, cost of hospitalization in this example. You would also look at the cost year on year because that gives the uh, payer an idea of when is the change occurring due to the market uptake that has been projected. Can if there is sudden increase in the year 3, can I look at treating less patients? Can I restrict the number of patients being treated? Is there a ethical way of doing it? And can I look at a smoother increase in my budget? When you so this is the total budget. Again, if you will see in the tables, what we have basically done is segregated the budget year on, not only year on year, by also the budget type or the cost type. This kind of transparency would always be required for the budget impact analysis. And even if you do not have enough space in your manuscript, this would need to go in as your supplementary files. Not reporting this segregation is one of the reasons that bias creep in into your results, and your results become less robust. Clinical outcomes are also good to include because that shows the physicians, it allows the physician or the payers to take the two-way look at it. So what is the improvement in the clinical outcomes, what is the improvement in the or the cost savings, and hence should I include it or not included it. It's similar to what your cost effectiveness analysis was looking at. It was also looking at cost and outcome. Here also we are looking at cost and outcomes. One of the biggest pitfalls is that if there may be inconsistency with the cost effectiveness analysis, which may also have been conducted, the costs taken were very different for the same healthcare resource. The cost, if they are taken, is different, or the way of costing is different. Then there is a difference in the results, which will not match the cost effectiveness analysis. What you will see is that a lot of time budget impact modeling is in fact included within the cost effectiveness analysis, or a merged cost effectiveness analysis plus a budget impact analysis model may be made, which just makes it easier to remain consistent with the cost effectiveness analysis. Similar to cost effectiveness analysis, you are going to have uncertainty in the results because some of these costs that you have taken, some of these outcomes that you have taken are assumption based. So you would need to run a scenario analysis or sensitivity analysis, and usually these are excluded because they are slightly difficult to run in a budget impact analysis, but should ideally be done. Now, your Scenario analysis would also always be used when there is a difference in the key parameters included or not included, and there is a difference in the structure of the model. In case there is a difference in the input that is used, then you would be running the sensitivity analysis. So you would do a base case. Here they looked at 1 year time horizon, 5 year time horizon, difference in the length of hospitalization that they looked at, and other factors which were leading to a structural change in the model. Usually, time horizon, efficacy, outcomes, any subgroups, any assumptions on the uptake curve, it's done in the scenario analysis, basically because there is uptake curve is never very fixed. Sensitivity analysis. I'll just take a couple of minutes more and then we can go on the questions in the interest of time. In the sensitivity analysis, again, the idea is to identify that what are the key parameters which are impacting the budget, and your top of the tornado is going to show you that these are the factors which are impacting the budget the most. In case there is a high uncertainty within these factors which are impacting, then your results may not be that robust. Another question that usually comes in is that what is the variation that we used to be using? Some people use plus 10%, 20%, 30%. Is there a fixed way of looking at it? Ideally, if you're looking at the data, you should be looking at the confidence intervals, and the variation that you're using should be in line with the confidence intervals. Example being, if the confidence intervals are very wide and you're only using plus to minus 10% variation to look at your sensitivity analysis, you are not going to cover the whole value, right? On the other hand, there is still no guidelines which say that how much the variation should be. All I'm saying is that look at the confidence intervals. If there are no confidence intervals, perhaps use 20% variation, so at least you get an idea, and the tornado can be made because it gives you that what are the variation and what is the result of that variation on the budget impact. With that, I'm going to stop for questions.
Thank you, ma'am, for such a wonderful session. In the meantime, people ask their questions. I have one question for you, ma'am. Ma'am, I know you are a trained surgeon, and your professional journey has been really inspiring, where you have led multiple teams successfully, being it oncology, RWE, pharmacoeconomic modeling. Ma'am, what kept you going?
So much, Richa. And this actually ties in with your presentation yesterday. That one, a background in HUR or a degree in HUR was not never required, and it's still not required for this profession. What is required is the understanding and knowledge, and that knowledge can be gained from anywhere. It can be gained even from YouTube. There are plenty of courses that are available, plenty of people who have presented what are the different ways of doing it. You go, do it, get a basic understanding, come to the profession, and keep learning on the job. And I think that was what kept me going, that every day is a new learning experience, and every day I discover that, oh, I don't even know this. And each new project brings with it a new understanding. The second thing that always keeps me going is that I may not be directly be treating the patients, but ensuring that the right medications are going to the right patients is a big place that keeps me motivated to keep doing these things, delivering projects, because day in and day out we tend to lose the perspective that what are we actually doing. Yes, we may be doing an SLR, and I may only be doing a screening for 1 month, day in and day out, but eventually it is going to help a patient get the right medication at the right time, and is going to help them. So
Thank you, ma'am. Thank you so much. And it's so inspiring to, I mean, a surgeon doing modeling, right? It's so inspiring. It's an example to all of us, right? That we can learn anything, we can achieve anything, and we should just keep going. I think questions have started coming for ma'am. Fatima, if you can please.
Yes. Ma'am, we have the first question from Akansha Verma, ma'am. Good afternoon, Loveleen, ma'am. It is a pleasure to listen to you after this long time. One question I have is, what are your recommendations for ensuring BIAs remain dynamic and update ready, especially when post-launch RW data changes assumptions?
Thank you, Akanksha. Uh, Two things would help. One is that you have the user inputs in addition to the default values, and the user inputs which can override the default values. That ensures that the user can update the data in case there is any change in the data itself. The second thing that we usually do is that we would include all of the relevant costs, even if they are not relevant for the current country, but they can be included as optionals with the option of including or excluding those parameters. What we have done also in the past is kept placeholders so that new competitors can be added as and when the competitors get launched, and it is easy for the payer to get the model updated.
Yes. Next question is from Krishita. Hello, ma'am. Is there any universal format for BIM across payers or countries?
The overall structure that I showed you on that slide, that picture, that comes from the ISPOR, guidelines on the BIA. So the guidelines and the structure remains the same. And similar to what I said earlier, you can have an option of including different parameters based on that country's requirements, based on the country's local practices. You can include or exclude those parameters. So yes, usually a global budget impact model would be made, which can be used or adapted for different countries.
Yes, ma'am. I think that's it with the questions. Thank you so very much, ma'am, for that lovely and insightful practical session. We are deeply grateful to you for sharing your contribution today. That was a truly enlightening session to conclude our morning program. This concludes day 2 of our morning sessions. What a wonderful mix of knowledge, case studies, and discussions around economic evaluations in HT in India. We'll now break for lunch and we'll rejoin shortly for the afternoon session as well as the abstract presentations. So enjoy your break, everyone, and see you all sharp at 1:30. Thank you so much.
IST. Let's be back. Bye.
Yes.
Yes.
Yeah.
Thank you. Thank you, Loveleen, ma'am. Thanks,
Thank
everyone.
you.
Enjoy your lunch.
Thank you.
Bye-bye. Bye. Bye.
Bye, ma'am.